Good morning, everyone. I'm so excited to be here. I am looking to Amber to help keep me on track because I have so much to say about this topic and I don't want to go over. So I think one of the quotes that will help us set the stage for the next 7 minutes are words that inspire me daily from Dr. Martin Luther King. And he said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So we're talking about inequality in terms of access, inequality in terms of treatment, inequality in terms of representation, because we each deserve that opportunity to see ourselves reflected in the healthcare institution during a time where we're all most vulnerable. And I firmly believe that we all have a moral obligation to put an end to health disparities in this country. And so what can we do when we know that the problem is so vast and the issues that lead to such disparate experience within the healthcare systems are so complex? I would assert that one of the things that we can control and that we can influence quickly is investing in our healthcare workforce with increased physician and healthcare workforce diversity. And so when we think about the terms of equality and equity and justice and our obligation that we have to pursue justice, let's think about some of those barriers that keep us from reaching the sort of the outcomes that we would all like. This barrier looks different for each of us. If we look at that middle sort of equity slide, what's keeping us from being able to experience our environments, our healthcare environments equally? One of the issues, and sometimes people, they'll paint the picture of all of the things that are wrong in terms of issues pertaining to diversity, equity, and inclusion in healthcare. They'll spend 45 minutes doing that. In the last 2 minutes, they'll give some potential solutions. I'm going to give them to you right now. One of these barriers, this wall that's in front of us, is this consistent urge for healthcare organizations to put issues related to diversity, equity, and inclusion in the margins. We create a DEI committee and let the diverse people figure out the problem. That's no longer acceptable now. Issues pertaining to equity, diversity, and inclusion have to be strategically interwoven in the mission and vision of every organization and every department and division within healthcare. And what that means is that you have to have stakeholders, you have to have representatives at every level. We heard Dr. Capel talk about that already, not just assigned to the Diversity and Inclusion Committee, which is where a lot of our organizations have been very comfortable. One of these barriers sort of in the middle has to do with how we engage with our communities. I heard Dr. Capel say that we need to be co-PIs. I think of it like a marriage. We need to be with our communities in sickness and in health. We can't expect them to trust us in sickness if we're not there for them in health. We need to change the way we're thinking about how we engage with our communities. And finally, we have to be transparent. That means we have to share some of our dirty laundry in healthcare, and we have to share it within our institutions and organizations and beyond so that we can learn from one another in terms of best practices. Those are some of the ways that we get towards this justice so that we no longer are having Dr. King's words truly resonate about how shocking and inhumane the inequities can be. For those of you who may not be familiar, let me share with you some of the statistics that led to the NIH characterizing certain groups as being underrepresented in healthcare. What that means is in comparison to the US population, this is what the demographics of the current physician workforce look like. This information is available at the AAMC, American Association of Medical Colleges. They do a diversity in medicine report every couple of years. And so these are the numbers that were captured at the end of 2019. I believe everybody in this room is aware of the crisis that we have in our Indigenous and Native communities. We're going to hear more about that. These numbers and these disparities get even more marked when we start talking about the representation in specialty care. So at 44 years old, I am the first Black woman neuro-oncologist. That's appalling that we're talking about firsts. I'm 44, I'm not that old. That means there's not someone who looked like me, doing what I do, who I could say, hey, how did you get that done? Or who could sponsor me or mentor me, right? So we really need to think about not just representation within primary care, but also as it exists in specialty care. So when we think about those barriers in that slide before, it's hard to, Marian Wright Edelman said it, you can't be what you can't see. We have to start seeing representation, thank you. We have to start seeing representation at all levels throughout the healthcare system. Amber, I'm gonna go 1 minute over. You know, none of us got to where we are easily. We all have had trials and triumphs. Not one of us has received a handout. There are some things that are shared and some burdens that are unique to those of us that come from underrepresented backgrounds. So I realize I'm going to say some things that may make some of us feel a little bare or exposed. I'm going to take a deep breath. I encourage us all to do so, and we'll get through it together. We know that women and investigators from diverse backgrounds are historically underfunded. What does that mean for our understanding of disease? What perspectives, what questions have not been able to be answered because these investigators were not able to get their work funded? What does that mean for academic medicine and who sits at the table and who teaches our young people, right? When we think about the underrepresentation in medicine, this impacts all levels. And if we can't get the research funded, we are missing an entire perspective that we so desperately need. Many of us coming from underrepresented backgrounds and women deal with pay inequity. We also have rates of increased indebtedness coming out of undergrad and medical school. And we also have responsibilities often that extend beyond our immediate household. That's a significant burden that is not shared by all. If you've not heard of it, some people call this the diversity tax. If you're one of the few diverse people in the department, division, committee, all of a sudden you become the diversity expert. And whether it's your interest or not, you're the one that gets asked to speak about all things related to diversity, equity, and inclusion. You are the one that gets asked to be on the search committee to represent diversity. You are the one, though many of us feel a responsibility to mentor young people, you're the one that's often assumed to, oh, Dr. Porter will have you shadow. She loves that stuff. You'll be the one that will staff the underserved clinic. You will be the one to speak on, be the representative for all of the things. I've got Mr. Kelly back there supporting what I'm saying. All of these things are valuable. They are essential. But let me tell you, they take time. They seldom lead to an increased salary. They don't lead to academic promotion, which is the currency of academic medicine. And they frequently lead to burnout. And this is what causes such severe underrepresentation when it comes to academic medicine, because we leave. I mentioned already about firsts. Oftentimes, folks from underrepresented backgrounds lack concordant mentorship, sponsorship, role models, and as a result of all of these things, experience social and professional isolation. And we can't forget the bias. There's the bias that we feel that's immediately obvious that comes from our colleagues and sometimes even our patients. But there are those tiny instances that start to erode at our sense of belonging. And so all of this also adds up to that wall, that barrier that we all have a moral obligation to try to break down. So I'm happy in the question and answer, I didn't talk about Elevate Med. That is a passion of mine, and I'm happy to talk more. But that's one of the things that I'm doing in my pursuit of justice. So thank you very much.
Thank you so much, Dr. Porter. Again, if you have questions, please write them. Your best handwriting that your first grade teacher would be so proud of you. Right there, please. So then we have Dr. Newland, who is the Chief Executive Officer for North Country Healthcare. So thank you so much for joining us, Dr. Newland.
Good morning, and thank you. You know, Dr. Capel's talk gave me a lot to think about, and it made me think, okay, I kind of want to switch up what I want to say. And I think he's right about PowerPoint, because I'm not quite sure how I'm going to make these stories link with the slides, but we'll make it a go. You know, they say power corrupts, but PowerPoint corrupts absolutely, and I think that's really true. But I think the big theme I would like you all to take away from what I say today is that we need to ground ourselves in the understanding of the particular. We need to embrace nuance, because it's by embedding ourselves in the particular of the communities we serve, of the lives of the patients we serve, that I think we can make some strides in improving health equity. So, as Lorianne mentioned, I'm the Chief Executive Officer of North Country Healthcare. I'm also a physician, so I'm trained in internal medicine and pediatrics. And really, when I started my medical career, I didn't think I would end up running a federally qualified health center. And honestly, like so many who end up in administration, I was the last woman standing at a couple of positions, but then found that I liked the work, and I liked the ways that you can toggle between understanding what's going on with an individual patient to working at a system-wide level and even in the policy level to influence the way we deliver care and the way we educate our learners. So this slide is part of grounding you all in some geography, letting you know where North Country has its clinics. Essentially, it's along the I-40 corridor here in northern Arizona. But you'll see that we also have a clinic in the Grand Canyon. We have a contract with the National Park Service. We're down in the Round Valley area. So folks of you who aren't from Apache County may not realize that that refers to the towns of Springerville and Eager. And this is a compromise name, because people come to blows over which community is superior, Springerville or Eager, and we just split the difference and call it Round Valley. We're also in Payson and in Mojave County. And each of these communities is different, has different needs, has different drivers. And we border a lot of Native communities and are in checkerboard areas where people go back and forth, sometimes seeking care with the Indian Health Service, sometimes with a North Country site. And that just contributes to the richness of the communities we serve. In the White Mountains, these tend to be heavily LDS communities. In Mojave County, the politics are definitely to the right, but the feel to me, honestly, is a little bit like Oklahoma. I'm originally from Nebraska, so and we have a football rivalry with Oklahoma, so I'm trying not to disparage Mojave County, but the feel is like I'm at a Sooners game. I also want us to ground us in the Navajo Nation. So some folks may be familiar with the different service units, how the Navajo area is organized, and these are the Indian Health Service service units. So when I first came to Arizona in 2004, I started as a medical officer in the Kayenta Service Unit. It's kind of that light blue block up in the northern middle of the nation, and it's where highways 160 and 163 intersect. And at the time I worked there, and I worked there for 8 years, we did not have a hospital. We operated a 24-hour emergency department and an outpatient clinic, in addition to dental and optometry. But the nearest hospital to the west was Tuba City, about 70 miles away, and the nearest hospital to the east was Chinle, also about 70 miles away. So being able to offer an emergency department level services was really, really important to our community. And I'll touch on this later, but this is also where the epicenter of the COVID-19 outbreak took place on the Navajo Nation. So folks who may be less familiar, There's a small community called Chilchimbito. It's not even a town. It just has a tiny little clinic and a water tower. But there was a Nazarene church rally that became a super spreader event on the nation. So I bring these things up because Kayenta is very dear to my heart, and we hit a staffing crisis years ago where we had to make a hard choice. Did we have sufficient staff to run the inpatient, the ER, or were we going to run the outpatient clinic? And working with John Hubbard, the Navajo area director at the time, we limited the ER hours. We closed at 10 o'clock or stopped taking patients at 10 o'clock and then would close at midnight and reopen at 8 in the morning. So in that community, that had a huge impact. And I was so gratified to have the support of the community to make those necessary changes, to get a contract in place and bring in ER docs. But when I went through the booklet of who they wanted to send to us, I'd look at the CVs and I could say, nope, don't want this guy. Nope, don't want this guy. Because for those of us who work in medicine, we know that medicine doesn't do a very good job of policing ourselves. And there were people that I were familiar with in this book, and there were people that I'd seen bounce from IHS site to IHS site, a couple steps ahead from the medical staff's ability to honestly get them out of medicine. And the person who was my point of contact for the contract told me that that people should just be happy for what they get, and felt that my standards were too high. And I really thought that that was unacceptable and just did not serve the community appropriately. So my solution, I'm just going to rush through the slides that are ones that you're probably familiar with in terms of social vulnerability, and just say that what we're doing at North Country is sponsoring community-based resident education, graduate medical education, so that by training people in the communities we serve and for the communities we serve, that we can create that population of physicians, clinical pharmacists, and dentists that our communities need and deserve. So thank you so much for your time today.
Thank you, Dr. Newland. Next, we have Francisco Lucio, who serves as the inaugural Associate Dean of Equity, Diversity, and Inclusion at the U of A College of Medicine, Phoenix. So, Francisco.
Thank you very much. Really happy to be here with everybody. The themes that our panelists have shared and our keynote speaker have talked about, they really resonate with me. I've been here in Arizona. Now it will be my fourth year. I'm going into my fifth year. I came from New York City, but one of the things that I did when I came to the U of A College of Medicine, Phoenix, was put together a strategic plan to address some of the things that folks have talked about. How do we integrate equity, diversity, and inclusion through the institution so that it's not simply relegated to one particular individual, committee, or office? And that was really important to think about. One of the things that we set out to do when I first arrived at the college was put together a strategic plan that looked at what we were going to accomplish in the next 5 years. And I thought that was really important because oftentimes ideas around EDI, I think, happen too haphazardly. And I wanted to be aggressive to put together something that was both a shield and a sword. My background is in law, and thinking about the Constitution and thinking about how we use the things that we write down as policies, procedures, and how we say we're going to do things is important. And I think it's proven to be really helpful. The focus of my my piece today really is, what were we able to do in order to integrate health equity into the curriculum for our medical learners, right? We are training the next generation of healthcare providers, and we want to make sure that health equity is something that's integrated in the work that they're doing. The ability for me to be able to do that really was founded in our strategic plan. One of the things that I knew that I had to do was increase the capacity of what we were going to set out to do in terms of educational transformation. Something that I wasn't going to be able to do alone, and so we created a position called an education and training specialist and sought out to bring somebody on board to help lead the charge around integrating EDI topics into our curriculum. At the college, we have longitudinal curricular themes, and one of them was cultural competency. And so students would learn about cultural competency as they're going through their system-based learning curriculum. But as we took a look at the curriculum, we realized, that's not enough. We need to do something that's more expansive. And although ideas around health equity were talked about, it was part of the language of the teachers and the learners, it wasn't something that was yet codified in the curriculum. And so we set out to change that. We wanted to transform that cultural competency longitudinal curricular theme into a health equity longitudinal curricular theme. And by doing so, we were able to really envision teaching around the topics that you see there. We articulated global theme objectives. The first related to unconscious bias. We know that teaching around unconscious bias is really important in terms of mitigating healthcare disparities that we see that originate between the patient and the provider and the patient. Social determinants of health, of course, something that is something familiar with groups, with the group here. Looking at healthcare and healthcare disparities, there oftentimes were conversations around the social determinants of health, but we weren't asking why, right? Why are we seeing those differences in different populations, and really getting down to root causes? And then really shifting our focus instead on cultural competency to one around health, cultural humility, and taking that shift and making sure that we're teaching our medical students about lifelong learning and not necessarily thinking about groups as static and monolithic. And then newly teaching around structural competency. And so how can we train our future physicians to be responsive to the structural challenges that patients are experiencing, and how can we give them the skills and resources to be able to address those challenges as they see them in their communities that they're serving. And so what we had to do was really take a look at our curriculum, and we've introduced topics around health equity into our case-based instruction, our patient panels, our doctoring course for our medical students. But one of the major challenges is that oftentimes our faculty haven't been trained in this kind of a way. When they went to medical school, medical education didn't necessarily focus in this way on health equity and these topics. So we are both teaching learners and we're teaching the teachers, and that's a cooperative kind of dance that we partake in, but one that's really important. We wanted to make sure that when our learners are rotating in their clerkships, that they had these opportunities to ask questions related to health equity. And so we really codified health equity into our learning objectives. All of our medical students, they are required to do a scholarly project, and so we encourage them to think about health equity and topics related to healthcare disparities as focal points for their research. To build on this, we made this as part of our strategic plan, and I mentioned that at the beginning. We wanted to create an elective course, and we were able to launch it this year, called Structural Inequities in Healthcare. It was really teaching a critical analysis to our medical students about those structures that patients go through and how they can be responsive to it. And we're touching on topics related to racism, politics, health equity. We're touching on mass incarceration. On Friday, tomorrow, we're going to take our students to the Lower Buckeye Jail and have them get an opportunity to speak with physicians who provide care at the jail to get a better understanding of what incarcerated individuals face, what formerly incarcerated individuals face in terms of health challenges once they leave being detained. And also looking at homelessness and cycles of poverty. The pictures there are a group of our students. We had a chance to really do creative things, take our students to the Phoenix Art Museum and look at a racial justice photo exhibit to be reflective and understand what racism and history has played. And finally, in terms of curricular innovations and integration, we were recently selected as one of the 10 medical schools from across the country to participate in an anti-racism transformation community of practice. This is led by Mount Sinai, and we're joined by other medical schools from across the country. But we're also developing a curriculum for anti-racism that we seek to improve, learn from our colleagues. But again, integration for all of our medical students and not just a subset, something that's really important. But thank you very much.
Thank you so much, Francisco. You guys been good on time, so I saw Amber hasn't, needed to waive things yet. So Tomas, don't make her, cut you off. So, but next up is Tomas Leon. He serves as the president of the Equality Health Foundation. So thanks, Tomas.
I know when she was talking about the time, she kept staring at me, so she knows me well. So feel free when you put the time up, jump up and down, do jumping jacks to get my attention. But muy buenos dias. Good morning to you all. It's great to be here. This is by far, as a native from Arizona, one of my favorite conferences. I've been coming to this conference for quite some time and always learn something new, and hopefully I add value to the conversations and the dialogue. So it's just an honor to be here with you, and everybody who's connecting via the internet. Welcome, and glad you joined us here at our Arizona Health Equity Conference. Jonathan brought up a number of great issues that sparked some new ideas and just reinforced my passion in areas that I've been working in, just like you have been, around eliminating disparities and advancing and achieving health equity for the communities that we serve. And it's a good time to reflect on our organization's vision and mission and strategic priorities. If you're centering your passion on how do we achieve health equity in the communities that we serve, Jonathan talked about deconstructing policies and systems and organizations, and I have the good fortune of actually creating a new organization centered on equity, health equity, and focus on eliminating health disparities. And so, I wanted to share what our North Star is. What inspires us at the Equality Health Foundation is our vision of equal health for all. So what I believe and what we believe is a society of healthy communities where every person can achieve their optimal health in life. And so in order to do that, we know there's a number of barriers that exist in communities and organizations that get in the way of good health for people and that get in the way of building healthy communities. And so that's why we've created a mission that's focused on eliminating or on leveling the healthcare playing field in diverse, underserved communities that we serve. And it's all about removing those barriers and creating new pathways to good health for people and for communities as well. And so it's a good time to go back and take a look at your organization's vision and your mission and strategic priorities and what's driving your work and supporting your work moving forward. So at the Equality Health Foundation, we were founded 3 years ago by our private company, Equality Health, and our founder and CEO, Hugh Lido. And we've been focusing on that side. We've been focusing on a delivery system that focuses on whole person care through the lens of culture. And Annabelle Castro-Thompson is here and Maria is here. They've been key in leading that effort to focus on culturally competent healthcare. Well, we know that what impacts your health and my health is more than just access and quality of care. 80% of the more is all of what we've been talking about, the social determinants of health, all of the root cause issues, the factors that impact your health and my health. And so that's why we founded the Equality Health Foundation, to focus on addressing those systemic issues of social determinants of health in the community. And our goals, our focus, our strategic priorities, or our impact goals are focused on reducing health disparities, expanding access to care, accelerating health education, not just health literacy, but really building that diverse pipeline of healthcare leaders and providers at all levels of the organization. Jonathan talked about all levels, and I think some of the panelists have touched on that too. And so that's what we're focused on. So just to bring it real to what we're doing now, or what we've been doing, when the pandemic hit, we knew that this pandemic was going to have a disproportionate impact on communities of color. Our thesis of our company was that the mission and vision of our company is centered on eliminating disparities and focusing on health equity. So we knew there was going to be a big issue that was going to impact communities of color. And to no surprise, the impact on particularly Black and Hispanic communities making up a disproportionate share of cases and hospitalizations and deaths. In fact, because of the pandemic, there's been a shortened life expectancy for the Black and Hispanic community by about 3 years. So we've lost ground on a lot of work that has been done. Thank you. We have to accelerate progress to address those issues. A lot of barriers that I won't go into all the details, from anywhere from child care issues, transportation issues, literacy issues, access to the internet, being in social bubbles, not getting access to the adequate information about COVID-19 testing, the virus, vaccines. A lot of barriers that had to be addressed that we came together with ASU CERT team, Dr. Flavio Marsiglia, our lead investigator, and some of us co-PIs. We designed a community health worker-led program to address testing disparities in communities across Arizona. So we're proud to be partnering with ASU and a lot of other partners we work with to start tackling and breaking down those barriers in communities and create greater access to testing for diverse and underserved communities. And then the vaccine rolled out. So we morphed into this one community initiative against COVID-19 and build a broad, diverse alliance of coalition members from public-private sector, including the Arizona Department of Health Services, Maricopa County, local municipalities like the City of Phoenix, and a number of healthcare providers and private organizations. This was the work of not one person or one organization. We had to unite and come together to address these major barriers and issues that were impacting communities of color. And so that's why we built this coalition and this comprehensive model to support a goal. A number one goal we had as an alliance, as a coalition, was ensure fair and equitable access to COVID-19 testing, vaccines, and wraparound support. And that's what our energy was focused on doing. And to date, we've reached nearly 51,000 lives and have had over 180 events that we've done, mostly in Maricopa, but other parts of Arizona. And soon we'll be partnering with the San Carlos Apache tribe to assist them in their surge action plan. They, by the way, have had a best practice and excellent interventions that they've implemented there. We're not coming to do something to them. We're just coming to partner with them and bring additional resources to help them with the surge from the Delta variant that has had an impact there. I'm wrapping up. Again, this is not done by any one person or any one organization. This is a partial list of some of the organizations that have gotten behind this effort together. We're tackling the barriers, we're creating greater access, achieving equity, and we're saving lives, and we couldn't do it without our partners, including the Valley of the Sun United Way that has stepped up to provide convening support for the coalition to keep us going so we can continue to focus on what we're doing best in the community, in the trenches, saving lives and protecting families, protecting individuals, and protecting our community. So I look forward to the dialogue and the discussion, and honored to be up here with my esteemed colleagues, and thank you for being here today.
All right, thank you. We're not finished, but you can start your evaluation, right? And your evaluation for this session should be the bright orange QR code whenever you're ready. Thank you for setting the ground for your work so the questions can really be, targeted to what you're doing. Thank you so much for your very neat handwriting. We are getting a lot of questions, again, virtually. Please put them in the chat, and Kim will make sure to bring them up here. And I will start with a couple of questions that we had for our session before, but I think that are really relevant to the discussion we're having here, and you will have the answers. So prior to the pandemic, the average visit with a healthcare provider was about 9 minutes, right, of an encounter. With the pandemic, all of those times have shortened. How do we support the healthcare workers in considering their own implicit bias in treatment when they're so busy and stretched thin and dealing with a pandemic right now? If you want to take it.
I'll try that one. I need to disclose my my own bias that I work in a healthcare organization where our time has not been significantly impacted. So it's important that you all know I get 60 minutes, 60, to see a new patient. I get 30 minutes to see a follow-up patient. So please take that into context with what I'm getting ready to share. In general, it is a very difficult time right now in healthcare. I think that for so many reasons, we were already stretched thin, and then the pandemic happened, and things got even harder. And once you add not just the stress and strain on the healthcare workers, but you add the anxiety of the public. Now we're also suffering with supply chain issues, like so many folks in the country. I was at Disneyland with my kids on Monday and Tuesday. There's boats in the water off the coast of California that have important resources that we all need. So the challenges are many, and the strain is significant. And I think that one of the things that our organization has tried to implement very quickly is gratitude. We recognize that there's not a whole lot that we can do right now to extend times. There's a shortage of healthcare workers that's happening now. That really is a challenge for all of us who are in growth phases within our organizations. And so making sure that the folks that we've invested so much in recruiting, that we want to make sure that we retain them and that they feel our gratitude. And that can look very different across the board. So, for example, yesterday I was part of a joy cart. We had a lot of snacks, some healthy, some not so healthy, walking through the hallways in the wards, thanking people for all of the work that they've done, recognizing that this is a very small token of appreciation, but something to truly acknowledge that we see them, we recognize the strain, and we want to acknowledge the good work that's being done. That's a simple thank you. A much more elaborate thank you is our institution across the board. So we call ourselves an enterprise, with the largest organization being the largest Mayo Clinic being in Rochester, Minnesota. So across the enterprise, we are having a day of gratitude the day after Thanksgiving. So everyone has been given a paid vacation day. If you are an inpatient worker who's not able to take the day off, there's additional compensation. In addition to that, there are gift cards coming people's way and different access for, they can purchase certain things towards their own health and wellness and all of that. That's a larger way of expressing gratitude. But I think that unfortunately, we're all in a really tough time, and so I don't have any magic anecdote. I wish that I did, because certainly we're seeking solutions for this very problem. But I recognize that the challenges are many, and they're made even more, they're compounded by the shortened appointment times, all of the PPE, which keeps you from being able to really connect. And in fact, one of the things that has given increased physician satisfaction as well as increased patient satisfaction is the access to having a virtual visit, because you can be, plain-faced and be able to really connect with your provider eye to eye. And so that's one aspect, but we recognize that there's limitations in terms of access to internet bandwidth to be able to have those appointments anyway, right? So it's a complicated, difficult problem. And certainly one that we're all working hard to seek a solution for.
Thank you. Any one of you wanted to add something regarding how the healthcare worker can address their own implicit bias? We have plenty of questions to go around, but thank you. So how can young professionals begin to build structures of equity, especially when looked at the newbie or the inexperienced? So our young public health professionals coming in the workplace. We're new, we're excited, we're seen as inexperienced. How do we bring that structure?
So I think this is an awesome question, because I like working with learners all across the spectrum, and these bright, shiny young people who have so many ideas and energy are fantastic. I love that energy and enthusiasm. What oftentimes younger people don't have is some perspective and an ability to be very strategic in how they move forward with action. So sometimes when young people are in conversation with somebody like me who's got a few more miles on my tires, it can feel a little discouraging. And I try to have those conversations so that younger professionals aren't discouraged, but I encourage them, who can you get to know? Like, learn from what's been done before. And the way to do that is build your network. Have real and meaningful conversations by people who've been in the trenches for a while. Don't let somebody's cynicism or negativity drag you down. Try to understand, why do they see the world that way? So I think we can all learn more in most situations if we're just intensely curious about why somebody thinks what they think or why they believe what they believe, and kind of set aside our own desire to create something. Start with understanding, and you'll get farther down the line.
I'd like to add to that. First of all, don't see yourself as inexperienced, because you have lived experience up until that point that you can offer to that organization or that team. And if you're in an inclusive culture, they're going to cultivate and tap into and give you an opportunity to share some of your fresh ideas and new ways to get things done and new perspectives. And so I just encourage you to get active, get involved, participate in some of the different committees or groups or projects. And some of it may be outside of your scope of work, but take the initiative to participate and be part of that and offer value, because you have a lot to contribute. And then the other, I'm just a big fan of mentors. My parents were very humble people, elementary educated, but they were very wise, and they introduced me to the concept of mentors and connected me with a lifelong mentor I still have today, Dr. Frank Felix, a former Arizona state senator, who has just been my lifelong mentor and helped guide me. And in the organization, you look for sponsors. These are executive level folks, people in the organization that can give you the code to opportunities inside the organization, and can also help guide you as well. But above all, don't see yourself as inexperienced. You have lived experience, a lot of wonderful innovation and new ideas, and organizations need that type of perspective and new ideas in order to achieve their mission.
And I would add, and echo what our panelists have said. But I've seen it so often from students or young professionals to be able to organize and ask a lot of questions, right? We often get in habits in cultures and in institutions how things are done, but going in with fresh eyes, asking why we do things the way that we do them is a great way to obviously learn, but also to challenge those who have been there, to reflect and ask themselves why, and perhaps there are opportunities there to embed some of those changes. But the young people, the folks who are coming in with fresh ideas and fresh eyes, really important to that cultural transformation.
Thank you. And this is another question from the audience, but I think it's a good follow-up, especially with some of the things have been said. I heard mentorship, find somebody. What if nobody in the room looks like me, speaks like me, right? So this specific question is directed to Dr. Porter and Francisco, but I think everybody other have an opportunity. If not us, who will dig, nurture, and prune the pipeline and help them to navigate those academic waters?
I'm so excited somebody asked this question. So I have the privilege of being able to truly do what I love in my day job and in my volunteer work. And so I mentioned I'm a neuro-oncologist. I'm also the medical director for our undergraduate Plumber Scholars Program, which is an undergraduate pathway program that we have at Mayo Clinic Alex School of Medicine. That's part of my day job. Part of my volunteer work is I'm an executive director for a foundation my husband and I started called Elevate Med. And our mission is to elevate medicine to an ideal where our physician workforce really reflects the population served. And so with these pathway efforts, it is critically important, with Elevate Med specifically, my husband and I, we wanted to create the thing that we wished we had. Number one is money. So we wish we had scholarship support. We come from loving families, but they were not financially able to foot the bill for our medical school. Number two is mentorship. We know the importance of concordant mentorship. And so we, within our program, have developed a mentor database. And these are filled with our friends of board members, folks who've reached out who say, oh, we love what you're doing. Can we be part of your database? And so students who are nominated for our program, as well as those that are selected, have access to this mentor database. And within that database, people's backgrounds are shared. What they do is listed, whether they're in academics or private practice, whether they're in an urban environment or a rural environment. And the only instruction we give to our students is to identify themselves as an Elevate Med scholar or Elevate Med nominee. And I firmly believe that even by seeing that list of names and seeing specialists, different specialties listed, it starts to open eyes and minds to what's possible. If you don't know what a dermatopathologist is, how can you say that you want to be one? If you've never heard of a transplant nephrologist, how do you know that you're not the one that's going to cure a disease? And so I think by having all of this representation, it truly makes a difference, and it creates access, which is really where the question is going. You know, in the age of social media, it's really, I think, a wonderful time for learners and those of us who are looking for mentorship, because there's so many ways to reach out to people now. And in fact, it can become taxing sometimes when you get lots of folks that are interested in meeting with you and talking with you. And so what I've learned along the way, because I recognize that at this moment, my time is a limited resource, sometimes people don't really need to talk to me, although they may feel that they need to talk to me. Especially if they're an undergrad, who they really need to talk to is a medical student, because they're trying to find out how to get into medical school. And it was 20 years ago that that I applied, right? So sometimes just being a connector is a great way to provide a form of mentorship to be able to get people really who it is and what it is that they need. But I'll say that social media is an excellent resource in that regard.
Thank you. I will add one piece for you, Francisco.
Sure.
Same question, but should we add these additional responsibilities as part of the professor pursuit?
So I'll start by saying that the minority tax is real. I see it all the time with colleagues. If you're a woman, you had to push the women initiatives. If you're a person of color, you got to push the initiatives that reflect that. And it's something that we're trying to change from a cultural standpoint. We practice inclusive excellence, and we say that advancing equity, diversity, and inclusion is a responsibility of every single individual, no matter what position you have at the college. And we put initiatives behind that. And so I see my role as an activator to advance equity, diversity, and inclusion, and we have to engage every single individual. And that is communicating out from the top down, and so really engaging your executive leadership voice, and having them send the message that this is everybody's responsibility is really, really important. And that will help it to cascade into the other parts of the organization. It's something that's sometimes easier said than done. And we've been working on this for the last 4 years, but we've started to see this change. We've started to see engagement from a lot of individuals. And we've been very purposeful, as was mentioned early, to engage, in particular, white men. Engaging white men at the institution, really important, because they are oftentimes the folks who are going to be those executive level leaders and also those mid-level leaders. But getting their support, sponsorship, critically important. And it's also important for them to be the face sometimes of this change. And as we sought to put together our 12 action steps toward inclusive excellence after the murder of George Floyd, Breonna Taylor, and others, we're very intentional to make sure that our executive leaders were leading work groups and initiatives around the change, and it was not relegated to my office or people of color only. It was very, very diverse. So those pieces, really important. And to the question about is it part of your responsibilities, we have actually made it one of the goals to talk about in terms of your annual review. What did you do? What are your goals for next year to advance equity, diversity, and inclusion? So that's something that we ask everybody to think about and have documented.
Can I just put an excellent point on that? Know the difference between a mentor and a sponsor. A mentor will help advise you. A sponsor will advocate for you and give you the code to unlock opportunities within an organization. And use both strategies to help develop and advance your career. Just wanted to add that.
Thank you. And if you're from North Country, Dr. Newland is taking notes. So I think there's some ideas coming up the pipeline, maybe, some fun things happening up there. Talking about some questions that we're having actually specifically looking at physician shortage. So I'm going to do one for Dr. Newland, and then it will probably bridge into another one for Dr. Porter that we have. Physician shortage contributes to health disparities in the rural and underserved areas. According to National Residency Match Program of 2021, there's a little over 74 unmatched U.S. citizen PR medical graduates who could not get into residency. How can we harness this surplus of medical graduates who would be willing to work in those HPSAs, please?
The HPSA sites.
HPSAs, yeah.
High provider shortage areas. So it sounds like the person asking the question is focusing on unmatched U.S. citizens who've gone to an offshore medical school in the Caribbean, in Mexico, in Europe, and why are they not getting slots? So I think there's a residency match. So there's a lot of things at play for graduate medical education. First and foremost, we don't have enough residency slots in the United States for all folks who would want a residency position. And there was a good study that was published by the Nikansen Center. And I have to apologize, I don't know much about the Nikansen Center, but it's Nikansen, and it's written by Robert Shore. It was published just in September of this year. That does a good job in the first part of the report talking about the policy changes that had been implemented in the United States years ago, like back before I was in medical school, that led to a primary care shortage in the United States. So some of their policy prescriptions, they've got about 10 or a dozen at the end of this report, include expanding the number of residency training programs. And that's what we're doing at North Country. So you can't match a resident if you don't have a spot for that resident. And if you look at ACGME, the Accreditation Council for Graduate Medical Education, in like the last 10 years, they've gone from, let's call it 200 some, I've seen the figures, but I don't remember them off the top of my head, to over 800 sponsoring institutions for graduate medical education. And where you see that growth is in entities like mine that are starting maybe 1 or 2 residency programs rather than the traditional academic medical centers that might have a half dozen or more training programs, you know, like University of Texas Southwest, they've got a bunch of different training programs. North Country just has one. So there's been a lot of change going on in the background, but you have to do that to actually get to the residency slots. And it's a journey to get sponsoring institution accreditation and then get program accreditation.
Thank you. Dr. Porter, how do you think the rural versus urban physician shortage influences the shortage based on race and ethnicity or gender? Is there an interaction? So we have the shortage and then we don't have enough representation.
Right. You know, I think one of the drivers of community and how we contribute to our communities has to do fundamentally with education within that community. That's really where the pathway begins. And so that's really where the dreams start for so many young people that say, I want to be a physician and I want to be a physician right here because this is where I love. I practice medicine right now 2 miles from where I went to high school. So I think that my story is not necessarily unique. A lot of people want to go back to where they're from, but that's another push for why we have to invest in our communities and invest within the pathways. And so to build on what Dr. Newland was saying, yes, there's a shortage of residency slots at that primary care level. But then we have the opposite problem when you start getting into specialty care. So for example, with what I do within neuro-oncology, we have way more fellowship slots than there are applicants. So you end up having fellowship slots go unfilled. And we know that we're going to need more neuro-oncologists. So again, we have a pipeline problem where we can't even get people that have worked so hard to get into and get through medical school and graduate. We need to get them into residency programs. And then not only do we need to get them trained up and in the communities that they're coming from or the communities that they desire to influence and help, but we also need to get them into the specialty practices. And so certainly that's an area where there are structural barriers that have to be broken down so that we can pursue justice in that way.
Do you mind if I ask a question? So to what extent do you think that debt issues are affecting people's career choice?
100%.
Yeah.
You know, cost is the number one reason why diverse, I'm using the word diverse today instead of minority. There's nothing minor that non-white populations have contributed here. Cost is the number one discourager for bright, diverse students who are going into medical school. They're choosing to pursue other careers that will get them paid more quickly and doing the work that they want to do much more quickly. It's a long road when you choose to pursue a career in medicine. And because of those other obligations, because of some of those barriers that we talked about within some of those burdens that underrepresented folks face, all of those reasons are why bright medical students from bright undergrads from diverse backgrounds are choosing not to pursue careers in medicine. And we need to invest in them to encourage them that there are ways that we can help support.
Thank you. So I'm hearing you talking about pipelines, right? And so we have a question looking at what have each of your organizations done to create a pipeline program for minority and first generation students. So we're talking before they even reach the university, you have to want to be something, right? And then decide to go to school for it. So anything that you can share with us that you know, so we're talking about pre-university, building the workforce from, I don't know, 8th grade, 7th grade on, you know, making sure that students see themselves as a neuro-oncologist.
At Mayo Clinic, there's been a few different strategies that have been employed. One of the things that's difficult is we know that we need change now. And this work is not for sort of the faint at heart, if you will. This is a long game that we're playing. We're talking about results that we won't see for 10, 15 years. And so certainly there are programs that are aimed at the younger generation, but also we're working sort of from the top backwards. So we have programs in place for residents that are of diverse backgrounds to help cultivate their professionalism, their experience, such that they may want to join our faculty. We have programs in place for diverse medical students to expose them to the different residency programs that we offer at all of the Mayo Clinic sites, such that they might see themselves as residents within our programs. We know that residents are probably our greatest pathway to staff, building up our staff, so that's the next immediate step. We have the undergraduate pipeline program that I'm the medical director for. Our sweet spot is our current second-year students, and so this is our 4th year of the program. We're kicking off actually next weekend, and we have over 100 students from across the country, various colleges and universities. And the program has always, even pre-COVID, been virtual. We were using Zoom before Zoom became so popular. But we have 4 webinars because we recognize that the health careers advisement that undergrads get really varies across institutions, and also, you know, there's some, you don't know what you don't know. So we start with the Med School 101. You know, these are the things that you need to know to get into medical school. This is the amount of money that you have to have saved in order to pay for the tests that are required. This is the amount of money that you need to have saved to pay for the interviews. Because those are barriers that are keeping people from applying to medical school. They just didn't know. We have other webinars based on how to use your summer. You know, taking the MCAT, a 30,000-foot view, and hearing directly from our admissions committees, and then the students can compete with each other for a summer experience at one of our Mayo Clinic sites. We also have a high school program called Mayo Clinic Cares that is local for our Arizona residents. That is really meant to expose high school students to all areas of healthcare, not just becoming a physician. And so that's been a popular program that I think is in its 3rd or 4th year as well. So again, we're trying to reach all of the different layers. It's complex. It takes a long time, but certainly we're looking to influence change. And with Elevate Med, the program that I developed, we're in our 3rd year, and we're focused on medical students already. So they have to have already been accepted into medical school. And we're looking to support them through to reduce their indebtedness so they can start to see themselves beyond what might be immediately available. So that's it.
Thank you, Dr. Porter. Dr. Tomas, you want to go next? Or?
At the U of A, similar to what you've heard of, about programs at Mayo, we partner with Title I elementary schools, and we went to them and we asked, well, what do you need? And they said, exposure to medicine and science, that's great, but we need tutors. And so they said, we're understaffed, our students need some help with math and science tutoring, and so that's what we did. We got our medical students to volunteer their time to go to these elementary schools and provide math and science tutoring, and then all the while being able to be those inspirations and mentors to the young children. We also have the largest sort of Turning a Medical School Inside Out program, Connect to STEM, that happens every year. COVID changed that to a drive-through through a garage, but still something that was really successful. Really hands-on, trying to excite young people. I got an 8-year-old and a 3-year-old, and if it's not exploding and lights flashing, they're not really that interested. But those are the kinds of things that we do through those programs for those younger years. And everything in the research literature tells us we need to go deeper and deeper into that pipeline to start to inspire younger people to want to pursue these dreams and plant those seeds to become physicians or scientists or other healthcare professionals. And then similarly, we have programs for high schoolers and undergraduate students. We have a cardiology academy for high school students focused on trying to meet the dearth of women cardiologists of color in particular. And we have a Pathway Scholars program for those individuals who are ready to apply to medical school, but perhaps for a variety of different issues have faced hardships and need an extra year to prepare. You apply to the Pathway Scholar program, you get in, you have a year of medical school training, and then upon completion of that program and meeting milestones, then you matriculate into that next year class. It's been a big source of being able to reach and matriculate students who are underrepresented in medicine. And so throughout all the different years, we have programs that target folks who are underrepresented in medicine as well.
Thank you. Tomas?
Yeah, we don't have a program yet that we're working on. We're still a young organization, but if you remember, accelerating health education is one of our community impact priorities. And I think it's important to recognize there's a lot of innovation going on right now around healthcare delivery. And there's new members of the care team that are emerging that are playing really critical roles in delivering culturally competent care, creating greater access and more efficiency in the way care is delivered. So I think it's important to continue to encourage young people to pursue a career in being a physician of different specialty areas, most definitely. But I think the role of a nurse practitioner, the role of medical assistants, the role of physician assistants, those are all very needed and critical roles. So as we think of pipeline, we need to think more comprehensively in terms of building the comprehensive pipeline of diversity in all those different roles, including community health workers. They're becoming an important member of the care team. So that's going to create access. That's going to create greater culturally competent care as we move forward and transform the way healthcare is delivered and the way people access culturally competent care in their community.
I'll just add one thing briefly. So some of you may be familiar with AzHECs. Has anybody heard of an AzHEC? Okay, so these are area health education centers. It's a HRSA grant-funded program, and here in Arizona, the U of A holds the main AzHEC grant, but then there's centers all across Arizona and other states as well, but they're specifically designed to help bring underrepresented folks into the health professions, defining health professions broadly, as you mentioned, Tomas, because I think that makes a big difference, and I think we also have to think about non-traditional students. So maybe it's somebody who's been in the workforce for 5 to 10 years, doesn't have a degree, but we can encourage and support them to get that associate's degree, go through certificate programs, because it creates professional opportunities and economic opportunities. And those are some of the stories that are really meaningful to me working in a community health center, because we think of ourselves, I mean, we host an AzHEC, the Northern Arizona Higher Education Center, but we also view ourselves as economic drivers in our community. So I have one person on staff who started as a patient relations rep, the very first line in the positions, and is now a clinic supervisor. I've seen folks move through and become clinic managers, get their degrees, and that's just an incredibly beautiful thing to see people from the community have a career path and gain all these skills within our organization.
Thank you. So we have a lot of questions, and lunch opened a minute ago. I don't know about you all, but I'm hungry. However, I do want to, by show of hands, and so hopefully you'll feel comfortable with that for our panel, because it is a question that comes from the virtual audience. Are your organizations involved? Because what I'm hearing a lot of things is around like policy change. There's policy for this, and we have to make more spots available. We have to break through the barriers. So are your organizations involved in any policy type effort, especially regarding healthcare coverage for all? Raise your hand if your organizations are, and maybe it's a place to start. That's a question we have from our live stream. Or one word, it's on the map, it's on the plan. We can't do it because Tomas, you have like 30 seconds, not even that, so.
Yes, it's on the map for us to advocate for health policies as part of a broader well-being transformation effort, dealing with people, places, and policies. That's that more comprehensive approach that we're going to be focusing on.
And I was going to add that we have a number of individual faculty who engage in policy and advocacy efforts. We have a course that teaches our medical students about advocacy, and so we're involved in those kinds of ways.
Yeah. And I would say we're involved in very specific health policies. So when people say health care for all, I'm always curious, what do they mean? Like in terms of a very specific policy proposal, because different people mean different things. In Arizona, just this past year, we advocated for House Bill 2392, which enabled federally qualified health centers to be eligible for Medicaid matching dollars for residency programs. The hospitals already receive $330 million a year through that program. So this is another way to increase the pipeline, but it was a very specific, very targeted policy proposal.
Yeah. Similar is true with Mayo. We have representatives that lobby on our behalf for particular policies such that we're engaged and certainly open to various community relationships where we're able to provide some access through our charity programs and all. So I think it's something that's certainly on the radar, and I guess the short answer to the question is yes, indirectly.
Thank you so much. Thank you so much